The information expressed in the following podcast is intended for educational purposes only and was created by and belongs solely to Believe Limited and the Flow podcast and does not necessarily reflect the views of our sponsors. Please speak to your healthcare provider before making any medical decisions.
We could all be in PJ pants. No one knows.
I don't even have pants on, so like.
Hello, and on that note, hi, I'm Jessica, and welcome to Flow. I'm here like every month with Sarah Watson, sex therapist, and this month we have Dr. Megnahn McCormick, and we are so excited to discuss iron deficiency and bleeding disorders and so much more. But first, we all want to know, how's your flow?
I am one of the very lucky women who does not get regular menstrual periods with my IUD, which, if you are not familiar, is an intrauterine device. Love it.
So when you say you don't get regular period, like you don't bleed?
My last period was probably about 2 years ago before I got pregnant with my daughter.
Do you have any symptoms of the cycle? Do you have any symptoms that show up cycle-wise?
No, not at all. Sometimes I get a little bit of like spotting, but that's pretty much it. No cramping, no crazy hormones. I love the IUD. I will push that for anybody who's interested.
Rock and roll. Well, Sarah knows.
I have an IUD
How's
too.
your IUD doing?
I am the queen of like my little best friend in there and promoting, but I do get symptoms, which is kind of a bummer, but I don't bleed, which is lovely. What's happening? We're talking
I know
about
things are happening, guys.
Periods and like
we're in America. The alarms are going off. Sirens are ringing.
That might be my background. I'm sorry.
No, it's cool. It's happening.
I live close to a busier road. So sometimes we get the fire trucks going by. The fire department's right next door.
Oh, well, they're going to go put out a fire.
Ring the alarm. Ring the alarm.
So I'm luteal. Jess, where are you?
Oh, wow. I am just wrapping up menstruation.
Lovely.
I'm just about to get into a new groove. Gonna get my groove back.
That's a good feeling.
Yeah. It is nice to come sort of like crawling out.
Although I always felt like I got a burst of energy, like at the point when I ovulated, that's when I could go for like a 7-mile run.
Oh, sure. Like right after.
Absolutely.
Like
the one day.
I was going to say it's only, I was like, did that happen for longer than one day? Because I get that one day thing, but nothing more. Yes.
I mean, training to the cycle would say that I do like the hardest stuff on my body around that time for sure.
Mm-hmm. For sure.
Yeah. For some reason, the extra power of the bloom is happening.
That's it. Embrace it.
Embrace it. I do. I embrace it. I also embrace that I've had some experience with iron deficiency, and I can't wait to talk more about it. But first, we're going to take a quick break.
This ad is brought to you by Von Vendy, Von Willebrand Factor Recombinant.
Hi, my name is Nicole. I didn't always feel empowered to speak up for myself or ask for the care and support I needed. Becoming part of a community and hearing other people's experiences helped to change my perspective. That's why my deciding factor is making my voice heard. To hear my story and access other helpful resources, drop by Von Vendy, that's VONVENDI.com/patient-stories.
And we are back. We have so much to talk about. Dr. Megnahn McCormick, thank you for being here. You are coming in from Miami today. Is that right?
I am in Miami. Mm-hmm.
And could you tell us about the work you do there?
Sure. So I'm a pediatric hematologist oncologist. So I treat blood and cancer disorders for patients 0 to 21 years of age. So anywhere from childhood to adolescence and young adulthood. But a big passion of mine is iron deficiency because I think it is very underappreciated.
Absolutely.
Heard. And really quick, so HEMONC, I just had to know, is an abbreviation for hematology and oncology.
Correct. Yes. And I had one mistake where I was trying to explain to my family once what I did. And I said HEMONC, and somebody heard gynecology. And I'm like, no, I am not a pediatric gynecologist. So hematology, oncology.
Those are very...
HEMONC. Sorry, Sarah.
That's okay.
I wanted to get back down to HEMONC. So HEMONC, in its own sense. Wait, you spell this HEMONC?
Yeah, HEM/ONC.
Okay, with a slash. And then, but you've also worked internationally, or you've published some articles?
I have an article published with the British Journal of Hematology, which they spell it HAEM, hematology.
Why?
I don't know.
No one knows. No one knows. Okay, just
because
curious.
it sounds fancy.
It's very fancy there. It's very fancy. It's very confusing when you read it. I'm like, wait, that's wrong. But no, it's probably us.
Just try to like skip past that extra letter in your head and move on.
Sure. Does that ever get confusing though when you're working cross, international borders with these kind of research studies? If things are spelled differently, does that not matter?
No, I think it's just an occasional, extra A, and I just try to read fast.
Heard. Great. Well, we know you didn't get into gynecology, but we do talk about extreme bleeding here on Flow. Can you just briefly tell us about your own experience with menstruation? Has it been an easy flow? Did you have any extreme experiences?
I didn't start my menstrual periods until I was 14. I was in high school. So I don't remember it being particularly traumatic. I was honestly just relieved to finally get my period. I was the last person I could find. I always had kind of irregular periods, so that was the biggest issue. I never knew when they were going to start or when they would happen. You always had to be prepared, and I don't know any teenager who's always prepared for that. There were a couple of accidents that were a little bit horrifying. And then I moved to an IUD pretty quickly as a young adult before I had kids, and I have stayed with that method, as I mentioned, since then.
How did you make it to the IUD quickly? I didn't have one until I was late 20s. So tell me, how did you make that decision?
Yeah, I guess when I say young adult, I was in medical school. So I started med school at 21, and once I figured out that it is the most effective form of birth control and it lasts for up to 8 years and I don't have to think about it, I thought that was go.
Yeah, of course. It should be for everyone, I believe. Just my thought.
I agree.
And then in medical school, what inspired you to get into hemonc?
I always wanted to do hemonc. I always actually wanted to do pediatric hematology oncology specifically. It's the first thing that I ever told any of my family members, and I stuck with it. I really like the opportunity to form these long-term connections with some of the families that we meet. You're there with them through some of the hardest moments of their life. And I really just have a passion for trying to explain things to families in a broken down way that makes more sense to them, so that they can concentrate on their families, they can concentrate on their children, and I can kind of help them come up with a plan.
Amazing. Did
you hear about hemophilia or oncology before? I mean, I think a lot of people hear about oncology before med school. That makes a lot of sense. But what about hemophilia? Like, did you hear about that before? Were you aware of bleeding disorders?
Probably not as aware of the hematology side of things as the oncology side of things. I knew about it in a vague kind of way, but nobody that I had specifically known.
Okay, fantastic.
So what was your first introduction to bleeding disorders in your education experience?
It was just in my medical school classes when we had all of our units on the different parts of the body, and hematology came up, and that's where it clicked for me, because nobody knows how to treat hematology. Oncology has these beautiful algorithms and protocols, and everything is so nicely laid out. And hematology is just a bunch of experts who all do things in a different way. And so I think it was kind of nice to be able to figure out what your practice was, take all that information that's out there and try to make the best of it.
Amazing. And then so within hematology as a department, your interest in iron deficiency, did that come from any personal experience or knowing anyone with iron deficiency?
Yes. So iron deficiency falls into this category called benign hematology. So you've got, your leukemias, your cancers, you've got your bleeding and clotting disorders, and then you've got everything else that falls into the bucket, which is benign hematology. Iron deficiency is exceedingly common. So almost every hematologist is going to take care of a lot of iron deficiency. And for that reason, I think a lot of people find it boring, but I really enjoy the piece where you get to educate families about why this happened and how do I prevent it from happening again. And to be honest, it's really rewarding because this is something that is so easily treatable. And you can make such a difference in how people feel and their quality of life, because a lot of times they don't even realize how the iron deficiency is impacting their physical and their mental health.
Absolutely.
Wow. Why is that? Why these people are fatigued? What are the symptoms that people are enduring without realizing that they have iron
Sure.
deficiency?
Yeah. So, I mean, a lot of people know iron deficiency can ultimately cause anemia if it's left untreated. But even before you get to that point, iron deficiency can cause fatigue. It can cause changes in cognition. So, young women and adolescents have been shown to have more difficulty focusing on their schoolwork and issues with memory and concentration or brain fog. A lot of times, athletes can report decreased endurance and decreased performance in the setting of iron deficiency. And then there are even things like hair loss, increased bruising. Sometimes alopecia can be related to iron deficiency. So, all these things that people just don't think about.
Wow. And so then when there is treatment available, what is the shift? When people take iron supplements, you see a shift in people's life and quality of life.
Mm-hmm. Iron deficiency can be slow to treat. So oftentimes we're thinking about 3 months or so of oral supplementation when we go the oral route. But as we correct it, people will start to say, I have more energy, I'm attending classes, I'm having an easier time in school. And they feel so much better.
I think that too, that
I
goes
love it.
hand in hand with like women with hemophilia, is that we are kind of taught to just buck up, right? Like advocate for yourself is definitely
Mm-hmm.
happening for some people, but I remember being like, I'm so tired, right? Like, and I already have incredible bruising, but then the bruising would be increased, and you're like, what's going on? Like, and then to be like, oh, you're deficient. Like, let's put you on something. And I'm like,
Mm-hmm.
I'm also gonna have, and I was for a while drinking a spinach smoothie every day, and they're like, ah, yeah.
That's
And my
perfect.
doctor's like, what are you doing? And I was like, oh, I have this green drink every day, and they were very excited about that. But the yeah, and I didn't
Self-treatment.
even know. I
Yeah.
was like, oh, this was healthy, right? But it really is something to pay attention to. And if you are a woman or a person with a bleeding disorder on top of it, it is just another thing for us to think about. And I was always asked about it when I go to clinic, but is it generally something that you're also asking client or patients? I have clients, you have patients. I'm like, your clients. But are you asking that right away? And are you running those panels? I know at my clinic that they do before I even see the physician. So,
Mm-hmm.
or see my doc. Is that something that is your normal practice with the kids, the kiddos?
Yeah. So, I mean, that's a great question because you're getting at the variability in provider practice right there. My practice has always been to screen any young woman who has heavy menstrual bleeding or a bleeding disorder with a blood count and an iron level once a year. If they've had a history of iron deficiency that's needed to be treated before, I'll check it every 6 months. I think a lot of practitioners, the practice varies. Sometimes people will only check if they're hearing these symptoms. And, sometimes you'll ask your patients, how are you feeling? I'm fine. Okay, great. Move on. And people can be so used to feeling worn down or tired that they don't even recognize that that's not normal.
Right. And I mean, and especially in teen girls, right? Like,
Everybody's tired.
right. They're like, I have to get up and go to school. I have to do my homework. I have to do my activities. And now I'm in clinic. And like, how do you differentiate, right? What is fine, especially with that age group? What is fine versus what is
Mhm.
typical? And then what is not? Do you have some magic scale that you use?
Ooh, I wish I had the magic 8 ball. Sometimes you just have to go with, okay, first off, do the parents think that it's a
Sure.
problem? If the people around you are concerned, that's usually a marker. And I also go with how much is it impacting your life? Like, are you tired, but you're still going to classes and you're going to after school activities? Or are you so tired that you don't even want to go hang out with your friends because you want to go home and sleep? I get a little bit more worried when it starts to impact the function piece of things.
Okay.
And what are some of the long-term dangers of not treating iron deficiency?
Yeah, so if you have iron deficiency and you don't treat it, likely the reason that you are iron deficient is going to persist. And eventually you're going to deplete your body's iron stores. And then you're going to start seeing changes on your CBC, things like anemia. And anemia can have its own risks. You can get physical symptoms like lightheadedness, dizziness, blurry spots. Some young women will have loss of consciousness when they stand up too quickly, they black out. So that can have issues. But there's also some studies that have shown that some of those cognitive changes, like learning issues and IQ changes, can be persistent if iron deficiency is untreated.
Oh, yeah.
Ugh. Figures.
Rough. So and are there studies being done to help support being able to determine what kind of research is being done into, I suppose, specifically iron deficiency?
Yeah, some of the things that I have seen most recently have really been focused on what is the threshold where we define iron deficiency. When do we decide we need to treat it? If you look at sources like the World Health Organization, they use a cutoff threshold of 15 for your ferritin. So ferritin is a storage form of iron, and that's what a lot of people will use to determine iron deficiency. They say 15 or higher for an adolescent, young adult woman, that's normal. But there are a lot of hematologists who use higher thresholds, like 30. And there's some data out there that really the ferritin that we should be targeting is 50 or higher, because there are some markers of iron deficiency that can be measured in the blood, some biomarkers that don't really normalize until the ferritin is 50 or over. And in addition, our body responds to that iron deficiency by trying to pull more in from our diet. And that doesn't really normalize until the ferritin is over 50. So there are some good reasons to think that maybe maybe iron deficiency is more prevalent than all of us think. Maybe a lot more of us should be on iron.
If under 50, if they've been categorizing, you mean at 50, 1.5 has been the marker.
Correct.
But perhaps it's 5.0. Yeah.
Correct.
That makes me want to. I'm gonna check my last labs as soon as we hop off of here and be like, where am I?
Yeah, I'll tell you, the last time I donated blood, they checked my ferritin when I donated blood, and I was not at 50. So I have a bottle of pills in my car that when I remember, I try to take them.
Okay. I don't think I am at 50. I'm pretty sure I'm not. So back to the spinach smoothie.
There you go.
All good systems. Okay, so this inspiration to ensure iron is getting to women, is that what forged the Iron Women? Is this a band of rock stars?
So I will say my mentor, Maggie Ragney from the University of Pittsburgh, is of the very strong belief that you must always have a catchy name.
Yes, we love it.
So the Iron Ladies is by Dr. Ragney, and I will give her full credit for that. But the inspiration for this was really just treating so many young women with iron deficiency and seeing how prevalent it was. But really, we didn't know if that is because, when you're in a forest, all you see are trees. When you're a hematologist, all you see is iron deficiency. So we wanted to know in young women who had bleeding disorders and who are at risk for iron deficiency, how frequently is it really being seen and how often are we looking for it? Because I was concerned there are probably a lot of women that were missing this in.
How does one follow what the Iron Ladies are doing? Like, where do you summit? What is it that you do when you gather?
Sure. So the Iron Ladies was a research study. We had two parts to it. We had a survey that we distributed to healthcare providers who worked at the hemophilia and thrombosis research centers. And we distributed it through a couple of email lists to get some information on how people were looking for iron deficiency, what tests were they doing, how often were they looking, how are they treating it. And then we did a study using a database that is collected from women who go to the hemophilia research centers and is part of the American Thrombosis and Hemophilia Network, or ATHEN network. I have to keep all of my acronyms.
There's a lot.
Yes,
there's a lot.
understood.
We know all about it.
And sometimes there's an extra A, and sometimes there's an extra A in them,
Exactly. Sometimes there's more letters. I might have just thrown a few in there. So the ATHEN network collects data from the hemophilia centers And originally it was formed to help track outcomes among men with hemophilia. But obviously, as we have identified, these women who also have symptomatic bleeding concerns, we do collect data in the database from those women as well. So we looked at how frequently are we getting iron labs tested, how frequently are we identifying iron deficiency, what seem to be the risk factors. And the main points that we found from our survey-based instrument, we found that everybody does something different. Not shocking there.
Not shocking, Sarah. Not shocking.
My favorite word, shocking.
Right.
Shocking.
Everybody says they're testing for iron deficiency, but nobody says that they're doing it all the time. And so a lot of people, the most common reason they were testing for iron deficiency was based on symptoms, which, as we said, can be a little bit misleading.
So, okay. So how do we normalize? Like, how do we spread the word within patients and providers that this is something pretty serious and that we should, like, why is there no standard of care when it comes to iron for women with bleeding disorders? I mean, but that's I know that's a loaded question, but
I know.
I was like, oh, as I said it, I was like, oh, it's gonna be a tough one. But.
I mean, I think the biggest thing that we can do is education, right? It's education. It's making sure that our patients know that this is a risk so that they are asking for this or bringing it to the attention of their providers. And it's making sure their providers know this is something that should be screened for also. The thing is, right now, there's not really a guideline specifically for these women who have bleeding disorders. I had mentioned in the article that we published on the Iron Ladies, the American College of Gynecology recommends that adolescents who have heavy menstrual bleeding should have a screening ferritin done, I believe annually, but that doesn't necessarily pertain specifically to women with bleeding disorders. And I'm not sure if every hematologist or provider within the hemophilia centers is routinely reading ACOG bulletins.
Probably not.
Right. So that's probably more relevant for these young women who are seeing gynecology for their bleeding, but not necessarily seeing a hematology provider.
Interesting. What is this? The ACOG report, though.
Yeah,
I know I said it in jest, but I wouldn't read that as a civilian, would I? Would I go look that up?
No, you wouldn't.
Okay.
This is the American College of Gynecology, and these are guidelines put out for gynecology providers.
Copy. Thank you for clarifying. So yeah, how about the communication between gynecology for the sense of awareness of menstrual activity and hematology for the awareness of all blood activity? How is the interface? Do you find there's communication?
Yeah. I mean, so in a lot of bigger centers, there is some really great opportunity for collaboration. So for example, in the clinic that I work at, University of Miami, once a month, they do have a clinic where there is a pediatric gynecologist who meets with one of our pediatric clotting doctors, and they see patients together. And so they come at things from both aspects and really make sure that that heavy menstrual bleeding is addressed, as well as any issues with the iron deficiency as well. I think it depends on what resources are available in your area. Sometimes it's really hard to get in to see a provider, and you might not have both of those providers available in the same space. In that case, I do think iron deficiency is something that most primary care doctors should be aware of and looking for as well, because this is so prevalent.
So what are some questions or some how can a person, especially, I think I'm thinking more about the older adolescent who is then going to transition out of your practice, and hopefully they're moving over to a treatment center for adults. But if they're not, what are some things that they can bring up or even kind of self report with their doctor? Like, how can we look at that? Like heavy bleeding. Okay, yes, check. That's all of us who have hemophilia, but well, not all, but most. Right. So, but like, how else can they be looking at that so that they can then advocate for themselves? Because I think that's been kind of the journey of Flow, is learning about all of this information and the research. But then a huge point is, how do we advocate for ourselves? Because I understand what's going on, but I am deep into figuring out what's happening. But I'm also in my 40s. I'm not in my 20s. So what does that look like?
Yeah. So I think making sure, if you are a young woman and you're going to a hemophilia treatment center or a provider, I think you need to be able to describe your menstrual periods in detail to your provider. And by that, I mean, a good menstrual history should be asking, how many days does your period last? How many menstrual pads or tampons are you going through on your heaviest day and on subsequent days? Are you changing it overnight? The thing is, a lot of young women won't be able to answer that question or don't want to answer that question. And that information is really, really helpful in telling us, how heavy is that menstrual period? Is this adequately controlled? What is your risk? So first off, I think women need to be really familiar with their bodies and able to describe their cycle. And then they need to be aware of any symptoms that they're having also, and not be afraid to say those. Sometimes I feel like we have this pressure to say, everything is fine, I feel great, everything's normal. And I would encourage our patients to feel comfortable bringing up their concerns, even if the answer is ultimately like, I don't have a great answer for that. I think everything is okay.
We do unpack sometimes the why of why it might be hard for a young menstruator to talk about it. But if we could take a moment from your perspective, do you bump up against the why, the cultural why, the embedded shame why, the reasons that it's hard to just talk about this bodily function?
I think a lot, I mean, it's a really hard question. A lot of women are embarrassed to talk about their menstrual periods. You can kind of see them get uncomfortable when you start to ask those questions. I always try to ask, first off, is there anybody in the room that you don't want to discuss this in front of? Because sometimes that's the problem. Do they have a family member there, a dad, a brother? They're like, I don't want to talk about this in front of you. And then once we make the situation as comfortable as possible, I say, I ask these questions to everybody. This is part of our routine visit, and I want to know so I can help take care of you. Part of it is that, sometimes they've never heard any of their friends discuss their menstrual periods, their parents, their family members discuss it. And so we build this idea that it's a shameful thing to talk about because nobody else says it. So then, we don't want to talk about it either.
Which is certainly what we're here on Flow to do, to sort of say the sometimes simple, sometimes complex realities that we encounter when we're dealing with menstruation, to practice the fact that it's just normal and important to bring up those details.
Right.
If you could talk to your younger self about menstruation and with everything you know now as a medical professional, is there any advice about your attitude towards menstruation that you would give, or even just practical tips that you would give?
Oof. Practical tips, I would say, please make sure to always carry a pad and a tampon. If not for yourself, then for somebody else.
Perfect.
Right?
Yes.
Because you also want to be the hero when somebody needs something. I mean, I would certainly say not to be afraid to talk to other people, or to feel like it is embarrassing to have to talk to somebody about it. Because on that topic, I had very irregular menstrual periods as a teenager, and I think that was probably abnormal. And maybe if I had let somebody in my family know, my mom was not aware. If I had talked about it, maybe she would have said, we should check this out.
Talk about it, ask questions, carry the goods.
Exactly. And try to, if you're a parent and you have a young woman who might be facing that time soon, try to talk about it before the menstrual periods start to happen, so that we know that this is a normal thing.
Yes. And I would also add to that is that whatever education, if they are in any school, which they should be, is not comprehensive. Right. So
Oh, no,
you've got
absolutely
to
not.
do the education at home as well. Like that's just a tiny little fraction of a health class. And it's not enough at all.
We on Flow are constantly curious about how often women are included in the research versus not. In the research you're finding that you read, and then in the research you're conducting, obviously, Iron Ladies, I'm sure we're focused on women included. Yeah.
I mean, I could go off on a whole tangent about that.
Please.
So a lot of my research relies on databases. So I have done research using several databases. So the data is already in existence. I'm not necessarily going out and recruiting women. However, I think it's pretty well documented that the Athens database has this very small proportion of women, and it collects very limited data on the female participants. And that's because Athens was originally created with the purpose of tracking outcomes in hemophilia, which was considered to be a man's disease, even though we know there are a lot of women who are affected by hemophilia. I think in the grander scheme of, and for the Appen database, I do know that they are working on creating more comprehensive data sheets to address bleeding symptoms that are seen by women in
Oh, great.
particular. And so they are working on addressing that. From like the research scope in general and clinical trials, because obviously I'm involved in some clinical trial work just as an oncology practitioner. I think a lot of it goes back to historical bias. So you may have heard of a medication called like thalidomide.
Mm-mm. No, what's
No? Okay.
No.
All right. So way back in, I think, the 1920s, there was this medication thalidomide, and they were testing it because they thought it would help reduce nausea in pregnancy. So what happened is a large number of women ended up having babies who were born with missing limbs, missing arms, missing legs, major birth defects. And as a result of that, the FDA put like a blanket ban on including women in clinical trials, any woman of reproductive age, because they were very worried that we didn't know what the effect of some of these medications would be on the unborn child. And they were worried any woman who could get pregnant, was pregnant, might get pregnant again. They didn't want to be responsible. There was a big liability. So for a very long time, women were excluded from trials, and everybody thought that the results of the men included in trials might be directly applicable. And I think it's been very hard to change that over time, even though obviously we want to include women in trials, and there's no longer a ban if a woman is of reproductive age. But because of that, there are a couple of things that have carried over. A lot of trials require women to be on some type of long-acting contraception to prevent pregnancy during a trial. Not every woman is willing to do that or necessarily wants to. A lot of times,
Also sorry, but then they also would be already on a hormone that would be changing the results. Okay, sorry.
Exactly.
Okay, sorry. Yeah.
So we don't always know how that hormonal form of contraceptive might affect the medication. Okay, there's that. There is the fact that we assume that men enrolled on the trial will have similar outcomes to women enrolled on the trial, and that is not always true. Women can process and metabolize medications differently. Some trials have shown that women actually have increased rates of side effects. So including women on the trials might show that the medication has more adverse effects than we were expecting or wanting to see. And
wanting to see from a like then we can distribute it for sale perspective.
Correct.
Okay,
Yeah.
just checking. Yeah. Mm-hmm.
Yeah, right. You can make that logical step. And then, lastly, you look to enroll patients, and women traditionally have these roles where they are caretakers, homemakers, responsible for a lot of things within the home. Enrolling on a clinical trial often involves a lot of extra visits for blood work and lab studies and, documenting medication compliance. And sometimes, that's a really hard thing to convince people to make those extra visits.
Yeah, where is the money for clinical trials goes to participants as well? Is that true? Does money go to participants?
There's often some form of compensation, yes.
Oh, yeah. And that is determined by whoever puts on the trial?
Correct.
And whoever puts on the trial, I'm like 101 questions, pardon, but like receives that money from whoever has decided the trial is worthy of a experimenting of action.
Correct. There's usually, it depends on what kind of trials we're looking at. So some trials are funded by, government organizations. Sometimes there are sponsors, which can be pharmaceutical companies, and the compensation provided depends on how the trial was designed and what was built into the protocol, because that all has to be approved ahead of time. Oftentimes there is not compensation. So the benefit of enrolling in the trial is that you might potentially get a medication that can cause some type of benefit. You don't want to be seen as influencing participation by providing something that, is only attracting people who really need that financial incentive.
And of course, at the same time, to be able to maybe pay for babysitting so you can go and experience a clinical trial, it would be helpful to have a flow of support. Interesting.
No, it's shocking. I mean, I think it's then I think about, okay, so how is this involved in capitalism? How is this involved in the mental load and the physical load of women in the home? of mothers, of women with bleeding disorders. Like there's so many layers. And then depending on who's putting on the study, right? Are they even putting energy into women's health? Because we know that there's not been a ton of research. And now, like, if you look at menopause, like everyone's like, oh, let's jump on that because finally there's a generation that doesn't want to deal with it. And now there's money there. And it's just like, it's a tornado in my brain and it makes me ragey. Okay,
I feel that.
Great. Plus the political landscape, because geez, where's the funding? I mean, because we don't know.
I don't think anybody knows right now. That is a very precarious situation at the moment.
Which is also why we need to continue talking to each other and about this to each other so that we are sharing information that we know can be valuable amidst whether or not institutions will be able to provide such things. This is why we're so grateful for your thank you so much for sharing the story of the history of the what was the drug called again? Sorry?
Thalidomide.
Thalidomide. No, that's fascinating. We've never heard on all our 5 years of Flow. That is an avid reason that we can point to say from then on, women were discluded. Wow.
Yeah, the history is very fascinating.
We're going to do I think you just gave us a new episode. Just deep dive into.
Come back.
I appreciate the opportunity to talk with you guys. This was a lot of fun. Like I said, I feel passionate about iron deficiency. I love having these meetings and going through the whole educational piece. I get handouts on like what foods to eat and like how to take your iron. And I think it's a lot of fun.
So then I'm going to be a little bit nosy. Are you presenting on Iron Ladies at any hemophilia conferences so that we can maybe work on a standard of care?
We presented our results at the American Society of Hematology, some of the initial results a while ago, and then at the American Society of Pediatric Hematology Oncology. And that article that summarizes our results is available through Hemophilia Journal. It's
Okay.
Yeah.
Great.
That's what I'm saying. The extra A sometimes. Yeah. Okay.
Yes. Cool. So that is available online. You can PubMed it.
Okay, perfect. We'll put that in the show notes because like people need to read this. Like this is again, the fact that we have to as adults and as women that are going to age out of your clinic, right? And that we have to advocate. So here's the information if they're not reading it.
I appreciate the opportunity. Thanks, guys.
You're doing amazing work. Thank you for flowing with us. And check the program notes for all those articles we were talking about. We will see you next time on Flow. Flow is produced by Bloodstream Media. Big shout out to our creative director, Amy Board, and our editor, Kay Vermeil. New episodes of Flow will be available the second Thursday of every month.
Hey, that's the day after I start menstruating.
And thanks to our sponsor, Takeda, for their support of Flow.